Good evening, everyone, and thank you for joining us today. We are excited to have all of you here for another wonderful patient webinar on macular degeneration, diagnosis, and treatments. My name is Gabriel Macias, and I am the Business Development Manager for Harvard Eye Associates. It's my pleasure to introduce our presenter for this evening, Dr. Sonia Dhoot, Medical and Surgical Retina Specialist. Dr. Dhoot is a board-certified fellowship-trained ophthalmologist who specializes in the medical and surgical treatment of retina and vitreous diseases. Her clinical interests include the diagnosis and treatment of macular degeneration, which is our topic of this evening, diabetic retinopathy, vascular occlusions, retinal detachments, macular puckers, and macular holes. Dr. Dhoot is also a contributor to medical literature, having authored abstracts, original papers, and book chapters. She has published in many different ophthalmic and neurologic journals and textbooks. She is a member of the American Society of Retina Specialists and the American Academy of Ophthalmology. And without further ado, thank you, Dr. Dhoot, so much for being here to host tonight's patient webinar.
Thank you, Gabriel. And thank you to all of you who are joining from home today. I'm sorry for a little bit of a delay. There was a little technical issue, but we like to keep this as informal as possible. This is really just a place for you guys to learn more about the disease. So please feel free in the chat box if you have any questions at all. Gabriel already knows as the evening goes on, and if you have questions, he'll interrupt me so that we can get all of your questions answered. So these are my financial disclosures. So I'm sure a lot of you are here tonight because you're afraid that macular degeneration is going to cause you or your loved ones to go blind. And that's the biggest fear I'm here to dispel tonight. Yes, macular degeneration can cause profound vision loss in its severe stages, but you can be rest assured that you'll never wake up completely blind. Macular degeneration only affects your central vision, so it's never a disease that's going to cause you to wake up in complete darkness. So what exactly is the macula? So this is a picture of what it looks like when we dilate your eyes and look into the back of the eye. The retina is like nerve tissue that lines the entire inner back wall of the eye. And this circular part in the center is called the optic nerve or the optic cup. And that's the cable that connects your eyeball to the brain. Optic disc and optic cup. The optic disc is the full circle and the optic cup is the small part in the middle. If you've heard of the term glaucoma, glaucoma is damage to the optic nerve. Off to the side in that circle there is an area called the macula. And the macula is a very small area, as you can see in the picture, but very critical for our central vision. Our macula is responsible for our color vision, our fine, sharp tuning of our vision, and our central vision. So even though anatomically it's a very small area, it's very critical for us to have good, useful vision. And this is the area that's affected in patients with macular degeneration. So this is kind of a schematic of what somebody with macular degeneration may see. If you look at the four corners of the picture, they look normal, as does most of the periphery of the picture. If you look in the center, the images appear warped and there's a black or grayish spot in the center. Any issues with the macula, whether it be macular degeneration, macular puckers, macular holes, macular edema, they all can cause straight lines to appear wavy or the presence of black or gray spots in the center vision, quite like this. In the more advanced stages, there's less warped images and frank just loss of image in the center of a vision. So in this picture, you can tell it's a family portrait, but making out faces is difficult. This is one of the things that people with macular degeneration struggle with is they see a person approaching them, but oftentimes they can't make out their face. And so they have a hard time recognizing people. So the World Health Organization this is a year old now, has listed the common causes of blindness worldwide, and macular degeneration is up there at number 5. In North America in 2019, 12% of patients over the age of 40 were diagnosed with macular degeneration. 90% was dry and 10% was wet. And we'll talk a little bit about the distinction between those two in a little bit here. With our population living longer and longer, we just expect these numbers to increase. So the projection at that time was that this number would increase 1.2-fold by the year 2030. This is just a graph that shows the percentage back in 2019 of the US population with macular degeneration by race and ethnicity. And so females are slightly higher risk than males, and Caucasian people are slightly more higher risk of developing macular degeneration than people that have pigment. And we think that's related to patients having lighter colored irises, makes them slightly more at risk for having macular degeneration. Another schematic showing the same thing and how much we expect it to increase with decades to come. Again, for whatever reason, we know females tend to be affected more than males, and we're not sure exactly why that is, but certainly does affect both genders. So what are the risk factors for macular degeneration? Unfortunately, the two biggest ones are age and family history, which of course are not in our control. The other ones that are non-modifiable, farsightedness, light iris color, female, Caucasian, we already spoke about. There are a couple of things that you can do to reduce the chance of developing macular degeneration, or if you're going to get it, making it so that it's not quite as severe. We know that smoking is a huge risk factor for macular degeneration, and it increases the risk by about 2.5 to 4.5 times. All the other things that are good for your heart, also good for your eyes. So high blood pressure, elevated cholesterol, a diet high in fats, a sedentary lifestyle, obesity, heart disease, all also modifiable risk factors for macular degeneration.
And then there's just a question, Dr. Dhoot,
Sure.
if you have time for that.
Yep.
So it says, what kind of injections are the doctors administering now? And are the doctors able to receive the injections since they understand the injections are coming from abroad?
So we do talk about the different, I'm going to talk about the different types of injections. There's lots of different medications that we administer. So we will talk about that in a few minutes here in terms of the names and which types of diseases they are candidates for, depending on what the stage of their disease. In terms of the manufacturing, all of our pharmacies that we get the medications from are from the US. So I'm not entirely sure where the abroad ones are. We don't, all of our medications that we inject are compounded in the United States. So of course, because it's so hereditary, there's been a lot of question about whether or not genetic testing would be a good idea. And so the American Academy of Ophthalmology came out with a statement in 2014 that basically says that they do not recommend doing genetic testing to see whether you're at risk for macular degeneration. Most of the reason for that is because there's really nothing you can do if you're at higher risk of developing it to prevent it from occurring. And of course, just because you have the gene for it doesn't mean that it will actually translate into you having the disease. And so this is not something that we typically recommend doing. There's really no quote unquote screening guidelines for macular degeneration, aside from just doing annual vision checks with your eye doctor, screening retinal photographs if you're at low risk. If you're higher risk and over the age of 60, probably worthwhile to get a good dilated retinal eye exam to make sure that there's no changes that are subtle that we may pick up on exam that we may not be able to pick up on the fundus photos. So the best way to screen, like I kind of alluded to, was to put dilating drops in your eyes to widen the pupils to get a very detailed look at the macula. This is way more sensitive than any of the photos that we take. This is an example of what we're looking at back there. And so with our lenses, we're able to get a 3D, very detailed magnified look at the macula. And this is the most sensitive way to pick up any macular degeneration. There's another test that we can use sometime in conjunction with our exams called fluorescein angiography. Fluorescein angiography is a way for us to look at the blood vessels that are growing underneath the retina with the help of a special dye. So in the office, we are able to inject a dye in your arm, which is kind of like food coloring. It's not actual contrast dye, so no risk of damage to your kidneys. And then we just take pictures as that dye circulates. That dye circulates throughout your body, but as it circulates in the blood vessels behind the eye, the way that dye behaves gives us a lot of information in terms of what's going on with the blood flow in the back of the eye. Are there new blood vessels growing, which would indicate wet macular degeneration, and whether or not we would need to initiate treatment. Oftentimes, we don't need to do a fluorescein angiogram, but sometimes if we're not sure whether the disease is still dry or if it's turned wet, we can use angiography to help us make that diagnosis. Most of the time, if you've been to an appointment with a patient who has macular degeneration, or if you have it yourself, these are the images we're looking at. These are optical coherence tomography, or OCT images. They're very quickly done in the office. They give us really great anatomical details of all 10 layers of the retina. And then very quickly, we can get a sense of what's going on with the disease process itself. The top image here is an example of a normal OCT macula. The one below, you can see there's kind of a little mountain at the bottom, and that's called a PED, or a large drusen, which is indicative of dry macular degeneration. But next to that, there's like a little sliver of black, and that's actually fluid underneath the retina in a patient who has wet macular degeneration, or the development of new blood vessels under the retina that are bleeding or leaking. So what exactly is AMD? So AMD stands for age-related macular degeneration. A common question we get is, well, how do I know my eyes aren't just aging and this is actually macular degeneration? There's really not there's no such thing quite as aging eyes. As we get older, certain things do happen to our eyes. Our lens begins to harden, and that's called cataract. Our optic nerves in some patients who are prone are higher risk of developing glaucoma. Similarly, patients who are high risk may develop macular degeneration. But these are diseases that we get as we get older and not just normal aging. So with dry macular degeneration, as you can see on the left, underneath the retina, you get the development of these calcium deposits called drusen. And these drusen are hallmark characteristics for dry age-related macular degeneration. On the right side, you can see that purple layer of cells has been interrupted by blood vessels that are growing into the retina, and that's called choroidal neovascularization, or wet macular degeneration. Wet macular degeneration typically tends to be more severe, and that's usually the type of disease that we will initiate injection therapy for immediately. So we like to use this example as an idea to give you a sense for how fast these progress. So I tell patients that dry macular degeneration is like the tires on your car. They slowly wear with age. So patients with dry macular degeneration will get worse, and usually that process is slow. Wet macular degeneration is like running out of gas. It gets worse quickly, all of a sudden, and needs treatment right away. So these are just pictures of what it looks like when we look in the back of the eye. On the left is that same picture I showed earlier that shows the normal anatomy of the optic nerve and the macula. On the right-hand side there, those are those very, very, very early stages of dry macular degeneration with those drusen. As you can tell here on this picture, those little spots are difficult to pick up, but if you look closely, there's tiny little yellow dots in the center of the retina that may be missed on pictures, but we would be able to pick up on exam. Again, here's normal on the left, and here's more confluent drusen, makes it a little bit easier to see, but this is a patient with early stages of dry macular degeneration. So now this is intermediate stages of dry macular degeneration. So you can see that there's those drusen there. And then there's also some kind of pigmentary changes, some darker brown areas in the center, meaning that the dry macular degeneration is progressing. This on the right here is a patient who has severe advanced dry macular degeneration. You can see those drusen really aren't there anymore, and there's big patches of what appear to be missing tissue, and that's exactly what it is. This is called geographic atrophy. So in the advanced stages of dry macular degeneration, there's pieces of the retina that actually go missing. And so because of that, these patients can have pretty profound visual loss as well. These patches of geographic atrophy typically start farther away from the center of the macula and slowly grow to encompass the central retina as well. And that's when the significant visual loss begins. This patient has end-stage dry macular degeneration, so you can see that patch of missing retina is very large, and I expect this patient probably can't even make out the big letter on the big E on the vision chart when when we check their vision. So what does this look like on those OCT scans that I mentioned earlier? So again, the top image on the right is normal. And on the bottom, you see kind of that lumpy, bumpy appearance of one of those layers under the retina, and those correspond to the drusen. So this is a patient that has dry macular degeneration, and that's what it would look like on their OCT. So wet macular degeneration can present in two forms. It can have bleeding in the macula and or fluid. And this is an example of a patient that has both. So on the left side is what what it looks like when we look into the eye. You can see there's bleeding in the macula. And on the right side, you can see there's kind of some black fluid underneath the retina. So there's fluid and blood. And this patient would be a candidate to start injection therapy right away. In the more advanced stages of wet macular degeneration, particularly if it's not treated in a timely fashion, those new blood vessels that are growing will scar down and create what we call a disciform scar. So this patient here has a large area that's scarred in the center, likely from having wet macular degeneration that wasn't treated maybe quite as aggressively as it should have been, or just in the more advanced stages. All right, so I'm getting to the treatment with the injections, which is what I know the question was earlier. Excuse me. So what would slow down aging is really the way to approach this, because that's essentially what macular degeneration is. So kind of what we talked about, all of those things that we know are not good for you, drinking, particularly smoking, are gonna make your disease progress much more quickly versus, living a healthy lifestyle will be more protective. We know green leafy vegetables, collard greens, kale, Brussels sprouts, spinach, those are all good. And then, of course, all of those foods that are high in fats are not. And then again, the sedentary lifestyle versus staying active. We also recommend patients with macular degeneration to take AREDS2 vitamins. There's been lots of different studies to show the exact doses that are recommended, and the AREDS2 is the one that's been shown to reduce the chance of macular degeneration progressing from dry to wet by close to 30%. So this is what we recommend. I spoke about dark green veggies. Those are things we recommend. Also fresh fish. The Academy says about 3 times a week will also be a protective factor. If you have been to an ophthalmology office and have macular degeneration, chances are you've seen a grid like the one on the right. So the top grid is obviously normal. We tell patients to look at this grid about once a week with each eye, because with both eyes open, one eye may be compensating and you may not realize you have a problem. What you're looking for are straight lines looking wavy, like the one on the bottom, and or black or gray spots in the vision. And if you see any of those are indicators that you could have macular degeneration, need to have, or some sort of a macular disease, and need to have a dilated retinal exam. For our patients here at Harvard Eye, we also have the ability to do remote patient monitoring, where you have a website where you are able to do an electronic version of this grid about once a week that your doctor reviews. And if anything changes from your baseline visit, it will alert us so we can call you to set up an appointment sooner, all in an effort to try to catch your wet macular degeneration as soon as we can. In general, patients with macular degeneration, because it affects their central vision, have a disproportionately harder time reading and doing near tasks as compared to distance. So I tell my patients with AMD the best thing they can do is to invest in a tablet of some sort. Tablets are nice because most things are available electronically now. You can change the contrast, so you can make the background very bright, make the letters very dark, and then make the font as big as you can. And that usually is a huge help because books are much more difficult to read. So bright lights, magnifiers, we have a visual aid device here in our optical department that we sell called Idaptic, which is really great for people who have profound vision loss at helping them move their image out of a place that they can't see into a place that they can see to help, with reading, grocery shopping, reading pill bottles, that sort of stuff. But really, we know that if you're going to turn into wet macular degeneration, this as quickly as we can catch it and start treatment, that's going to be the best thing we can do. So all of our efforts are really aimed at trying to catch it and start treatment as quickly as we can. Again, another patient of wet macular degeneration with a fairly large hemorrhage in the macular area. So to the treatments of wet macular degeneration, back in the day, the only option was to laser the macula. The laser worked well at destroying the new blood vessels, but it also destroyed the healthy retinal tissue around it. So it wasn't great because it would stop the new blood vessels from growing, but would also damage the surrounding healthy retina and leave patients with a large scar in the center of their vision. But since about 2004, we have had lots of different injections that have come out. One of the first ones that we started using, which we still use very often today, is a medication called bevacizumab or Avastin. Avastin was actually a chemotherapy drug that was used for colorectal cancer. We realized it didn't work so well on colorectal cancer, but patients were seeing better. So that medication became reformulated into a vial form, which we till this day inject in patients who have wet macular degeneration, as well as other macular pathology. Shortly after, we have had multiple different other medications come out: Lucentis, Eylea, Beovu, and then our two newest ones are Eylea HD and Vabysmo. And currently, we, Dr. Kim and myself, inject all of these medications in the office today. If you look on Google, there is a surgical implant that was introduced a couple of years ago. So it's basically a surgical procedure where a little port is inserted on the white part of the eye. And this port is just filled in the office to reduce the number of injections you would need to receive. I personally do not do this procedure. The infection rates were a little bit too high for my liking, about 10% chance of infection, which can be pretty severe and potentially blinding. So I share it only as, as to have full disclosure, but this is not something I typically offer my patients. So these are examples of patients with wet macular degeneration. At the top, this is the OCT macula, and you can see those black fluid-filled areas are areas of fluid that were treated with injections, and the vision went from 20/70 to 20/25. As long as there's fluid in the macula, we expect visual improvement as that fluid slowly clears. And then once that fluid's cleared, then the goal is to protect that vision and prevent it from getting worse. And so then the role of continued injections is maintenance therapy and not necessarily visual improvement. So again, the whole schematic with dry macular degeneration just slowly getting worse with time. With wet macular degeneration, I tell patients we don't have a cure. We have treatments, but we don't have a cure. And the reason I make that distinction is because it's like your blood pressure or your diabetes. The medications work really well as long as they're continually given. But the second you stop taking your medications, your blood pressure goes back up, your blood sugars go back up. And same sort of thing here. The second you stop taking those injections, your new blood vessels will just come right back. So really the aim is to see how long we can go between treatments without things getting worse. The most often we dose injections is once a month, and usually the longest is about 3 to 4 months, with the average in the US being about every 6 weeks that people need injections. There have been some studies looking at patients with large hemorrhages, as the picture on the bottom right there, of trying to surgically drain these clots. Unfortunately, they haven't been too promising and is not something that's done very regularly. We talked about this earlier, but living with severe macular degeneration, again, it's not a total blinding condition, but basically just optimizing your peripheral vision, learning to live with the vision that you do have. And that's what a lot of the low vision aids do. With time, your brain becomes better at this as well, from shifting the image out of the spot you can't see, maybe slightly over to an area where you can see. It's something that we call eccentric fixation, or developing a preferred retinal locus. So our brain is pretty remarkable in being able to kind of use the vision that we do have to try to get by day to day. So this is something that's newer. So earlier, we kind of touched upon the more advanced stages of dry macular degeneration called geographic atrophy, or GA. In the last couple of years, there have been 2 drugs that have been introduced to slow down how fast geographic atrophy lesions grow. Like I mentioned before, these geographic atrophy lesions start away from the central macula. And at that time, depending on how big they are and how close they are to the center, you may or may not have any symptoms, maybe a little bit difficulty reading. But with time, those lesions grow into the center, and that's when it becomes challenging. It affects about 20% of patients with AMD. And when it gets to the center, there's really nothing we can do for it. So this is kind of the normal progression of GA. So you can see this spot here starts out to the right, and it slowly gets larger and larger until it encompasses the center. So both of these injections, Syfovre and Izervay, are also given as injections, different class of medications than the wet AMD drugs. And unfortunately, these drugs don't improve the vision like our wet AMD drugs do, but they slow down how fast they get worse. And so the studies show that about 30% reduction in how fast your disease will progress. It's a little challenging because everyone progresses at different rates. And so a common question I get is, well, what does that mean in terms of time? Does it mean I'm going to lose my vision in 5 years versus 3 years? And that's a really difficult question to answer because we don't know how quickly every patient progresses. Every patient, every eye is different. And so it's a little bit of leap of faith, but we know that doing these injections, which are dosed between every 4 to 8 weeks, will slow down how fast your disease progresses by about 30%. So what's next? Dr. Kim and I just finished up a wet macular degeneration clinical trial here at Harvard Eye Associates. The results haven't come out yet, but we are unfortunately no longer recruiting. But basically, we're doing lots of studies on wet macular degeneration and new therapies that will either work better or allow our patients to go longer in between injections. So this one was a new molecule that targeted different molecules in the VEGF inhibition. And so it's used in conjunction with the other wet AMD drugs that we already have. And we're really excited to see whether this is something that we'll be able to use to help our patients long term. This is a picture of my 3 little ones. We recently just came back from a conference in Kauai. And so figured I'd share this and open up the floor to any questions.
Dr. Dhoot, it looks like we currently don't have any questions at the moment,
Okay.
but actually one just came in. Gabriel, do you want to go over that?
Yeah, it says, what about floaters with AMD?
So floaters are something that are very common after injection procedures. Usually they go away within the first couple of days to weeks after an injection, but with repeated injections, you can get floaters, very common. But floaters not related to injections are actually not related to macular degeneration most of the time. Hope that answers your question.
And then we have another question. It says, is there a substitute for Lumega Z since they went out of business?
Um, even Lumega Z was something that was it was an AREDS 2. Basically, Lumega Z, for those of you who don't know, was basically a liquid of the AREDS 2 formulation. It wasn't exactly AREDS 2. A lot of times AREDS 2 can be difficult on people's stomach. So I tell them if they can't swallow pills or if they can't take it, if they could at least even take one a day. But yeah, unfortunately, there's no other substitute at this time.
Thank you, Dr. Dhoot. And then one more just came in and it says, does AMD affect only one eye or both at the same time?
Yeah, good question. So it all by definition, it affects both eyes. It can be very asymmetric. So you can be, lose all of your central vision in one eye from advanced AMD and be very early in the other. But, in order to make the diagnosis, that's one of the things that we have to look for is that, that there's evidence of disease in both eyes.
Thank you, Dr. Dhoot. And then, okay, it looks like there's a couple more here. It says, any thoughts on MacuHealth versus AREDS2?
Yeah, so there's lots of different formulations of vitamins out there. I tell patients that the only thing that's been studied time and time again is the AREDS 2. So I really stress, as long as the bottle says AREDS 2, Preservision, Ocuvite, those are the ones that are currently recommended by our societies.
Okay, and this one kind of goes along with that. It says, should someone take 2 pills a day of AREDS to be effective?
So, if you look at the studies, actually, the AREDS 2 have been shown to be beneficial in patients who have wet macular degeneration in one eye and dry in the other eye. That's the only population that it has shown to reduce the chance that that dry eye turns wet by about 30%. We kind of extrapolate and just give it to all of our patients with macular degeneration because, yes, they're pricey, but otherwise they're just high dose vitamins. And so they don't really hurt. And so, I get questions all the time about like, oh, well, my mom has it. Should I take it? And well, it's really hasn't shown to be beneficial in those situations. So to answer your question, yes, you're supposed to take it twice a day, but if you don't fall into that category of being wet in one eye and dry in the other, you could probably get away with taking it less because technically in your group, it hasn't even really been shown to be necessary. But, we kind of tell all of our AMD patients to take them. I hope that answers your question.
Okay. Any other questions? Looks like that's it, Dr. Dhoot.
Okay.
Okay,
Well, thank
so
you all for attending tonight.
yeah, thank you so much for a wonderful presentation, Dr. Dhoot, and thank you to our guests who attended. If you do have any additional questions, please feel free to email marketing@harvardeye.com, and we will be sure to get you those responses over. But we do hope to see you at our next webinar event, and have a great evening.
Thank you, everyone. Good night.
Thank you.